aspirin. So let's talk about aspirin and the prevention of cardiovascular disease. When you're talking about cardiovascular disease, we mean strokes and heart attacks and problems with the peripheral blood supply or peripheral vascular disease. You know, it's an important topic. It's basically the leading cause of death in the U.S., cardiovascular disease. It kills about 900,000 people in the U.S. every year, so it does carry a significant burden. What I would like to cover today is primary prevention. So I'm specifically talking about preventing otherwise healthy people with low, moderate, or high risk for having a stroke or heart attack in the future from having an event. So we're looking at people who have never had a heart attack, who have never had a stroke, who, for all intents and purposes, are a fairly healthy group of people. Yet they might have low or moderate or even high risk of having a heart attack or a stroke in the future, primarily because of their family history or their current medical problems. They may be obese. So a lot of reasons, risk factors, if you will, that place them at risk for having a heart attack or a stroke in the future. This is called primary prevention, as opposed to secondary prevention, which is basically preventing another heart attack or another stroke. So it's looking at people who have had a stroke or have had a heart attack, and you want to provide secondary prevention, providing them some kind of medication or intervention that will prevent them from having another stroke. That's secondary prevention. The purpose of this video is really to focus on primary prevention, however. And what I do want you to know is that it's much easier to make recommendations on secondary prevention than it is on primary prevention. And the reason I say that is secondary prevention, you're taking someone who has already had a heart attack and you're saying, hey, take some aspirin to prevent you from having another heart attack. Pretty straightforward. Primary prevention, a little bit more complicated. You're taking people who have never had a heart attack, have never had a stroke, and you're saying, take a medicine that may have some side effects and take this in order to prevent you from having a stroke in the future. You have to look at risk factors. You have to look at the big picture in the patient and individualize this recommendation. So it's not something that we make recommendations as physicians across the board that, hey, if you're 40 years of age, you should be on aspirin. If you're 50 years of age, you should be on aspirin. No, we don't make those kind of recommendations. We look at the individual and we say, do you have risk factors for having a heart attack? Do you have risk factors for having a stroke? If so, let's consider placing you on aspirin. Let's look at the risks that you may incur when you take aspirin, and let's see if those benefits that you get from preventing a heart attack or a stroke outweigh those risks. So who do I recommend take aspirin? Well, let me phrase it a little bit differently. When you're looking at aspirin, this is the question that you should ask. Will taking aspirin reduce my risk of heart attack or stroke more so than increase my risk for gastrointestinal bleeding? The biggest risk factor that we see with aspirin is gastrointestinal bleeding, bleeding from your GI tract caused by the aspirin. So ultimately, we're asking the question, will you benefit enough from taking aspirin to overcome the risk of gastrointestinal bleeding? That's the discussion you need to have with your primary care physician. So who do I recommend aspirin for? Well, I can best explain this by giving you some examples. If I have a 45-year-old male with diabetes, who has obesity, who has family risk factors, his father died of a heart attack at age 50, then his risk factors for having a heart attack or having a stroke are high. I would like to have that discussion with this patient and say, look, you may benefit from being on aspirin, on a daily aspirin. Let's look at your risk factors for problems from being on aspirin, such as gastrointestinal bleeding. Let's talk about those risk factors together and see if you would actually benefit from this. Same patient, 45-year-old male, who's in shape, doesn't have high blood pressure, does not have diabetes, no family history, father and mother are both healthy and old and just doing well, no heart attacks in the family. So this person has low risk factors. I likely would not recommend aspirin for this patient. What are some tools that your primary care physician has in order to make this kind of educated guess? Well, there is a Framingham heart study risk scale that is available. And what it does is it looks at things like your age and your sex and your blood pressure and your cholesterol, and it calculates a 10-year risk score. So what is it? It's a risk of having a heart attack in the next 10 years. And based on that calculation, your primary care physician can make recommendations for you as to whether you should be on aspirin or not. So talk to him, talk to your primary care physician and determine if you need to be on aspirin. So what is aspirin and how does it work? It's important to understand platelets. Platelets are small particles in your blood that basically are responsible for forming fibrin and forming clots. And they play a key role in clot formation during heart attacks and strokes. So what does aspirin do? Well, aspirin is an antiplatelet agent. So it breaks down or fights off or deactivates the platelets. By doing this, we know it reduces your risk of having a heart attack or a stroke. How much aspirin do we recommend? Well, there's 81 milligrams, there's 325 milligrams, which we call the full dose, the baby dose being the baby aspirin at 81 milligrams. Several studies have demonstrated that really you get just as much benefit in primary prevention by taking 81 milligrams as opposed to 325 milligrams. As well, your risk for gastrointestinal side effects are higher in the 325 milligrams. So I recommend that my patients take 81 milligrams daily. I recommend that they take the enteric-coated dose and they take this tab once daily with food. There are patients who should not take aspirin, and these include people who have a hypersensitivity or an allergy to aspirin. And this can be manifested with asthma or rhinitis, allergic type reaction. You can also have urticaria or wheals. There's more like a skin rash. Definitely people who have had gastrointestinal bleeding or are at risk for gastrointestinal bleeding, meaning they're taking NSAIDs or they're heavy alcohol users, should not take baby aspirin. If you are a person that's had chronic low platelet counts, you should not take baby aspirin, or you should talk to your primary care doctor before taking aspirin. As well as if you are on blood thinners such as Coumadin or warfarin, you should have a discussion with your primary caregiver before starting aspirin. Other things to keep in mind is if you are taking aspirin routinely and you're planning on having any type of surgical procedure or dental procedure that's fairly invasive, talk to your provider and see if you need to stop aspirin. This is usually done 7 or 10 days prior to the procedure. That's basically a summary of aspirin for primary prevention.